And I think our next speaker, Professor Patrick Jourdain from Paris, is particularly well suited to look at specifically this aspect in cardiovascular medicine, because you have done some fantastic things, and I'm not going to preempt anything. I would just like to invite you to start your presentation on using COVID-19 learnings to further improve cardiovascular patient care.
Thank you, Stefan. So it's my real pleasure to be here, and thank you for the invitation. So here are some disclosure. So as we know, cardiology is really a changing world. So we come from ECG to connected T-shirts, to stethoscopes, to echographs, and from necropsy to calcic score, and from diet to stents. So it's a changing world, and cardiology is changing too. And so if you're looking at the impact of the COVID is new to challenge, not only for cardiology, but for all the healthcare structures, because we have an extent contaminations that need physical distanciation between patients, but also between doctors and patients, a medical exhaustion needing reducing appointments, stay-at-home instructions, reducing chronic diseases, follow-up, and medical therapy dispensation, and especially a dramatic inflation of patients' number at emergency room. And it was really scaring for France, and really a significant impact on mortality on COVID infection. But the worst problem for us in France was not only the patient with a very high risk, but the huge number of patients with small symptoms, but that will go to emergency rooms, that will go to the GP, and so on, and that can do a lot of traffic jam, and so it could block real severe patients. Another point was the use of all the testings. Yes, it was very difficult because at the beginning, especially in France, we were low in terms of a number of tests. And so it was very, very difficult to identify clusters as you have done in some other countries like Germany. But if you're looking here, the mortality impact of COVID, here is the mortality number. So each week, during the 10 last years, and you can see here it's the impact of the overhead crisis 15 years ago, where all elderly people were died by dehydration. And here is the impact of the Hong Kong flu some years ago. And here is the impact of the COVID-19 in France. And you can see that not only you have a huge peak, but also you have large time with a high mortality index. And so that's why now we are around 30,000 patients dead. But some others stress the community, saying that the cardiologic impact will be certainly worse than the impact of the COVID, because people don't go to see the cardiologist, but in real life. So we have less acute myocardial infarction, less heart failure decompensation, less stroke. It was especially seen by the neurologist, because we have a decrease in 45% of stroke during the epidemic of COVID. And one explanation is very simple. So the patient is taking the tablets because they don't want to go back to the hospital. And so it was a real solution in order to decrease all the cardiologist problematics. And we have already met such challenge in the past, but we lose. So it's not actually the pestis, but it's a high-risk disease. And so there is a lot of change. The first change is a change in publication policy. One thing is that you have actually around 1,000 papers on COVID in peer-reviewed journals, and most of these journals are opening for free other results. And it's very interesting because you can have a free use of the publication, and you can have a lot of people that read it and a lot of people that use it. The second point is that you have a change in the medical appointment, especially in France, as in other countries. The patient perceptions of the medical art have changed. And so telemedicine was not more perceived as a low-value medicine, but a means to protect patients. And healthcare professionals were unable to do an examination to have no more patients because no time, or the patient don't go to the medical office. And in some countries, phone call consultations become available. In France, before the COVID, it was impossible to do a phone call consultation. You have to have a video call. And so it was more complex and it was very difficult to do in real practice. And so actually there is a new advance to say, okay, from phone advice to virtual visits. So we can do a very, very good clinical, not really a clinical examination, but you could discuss with your patient, you can prepare it, you can do a very good contact with your patients using the video, but also using the phone. And it's very useful to note that actually, so some papers focusing on how to do a successful virtual visit. And so we can see that in most of the cases, we can see patients with virtual visits, especially in patients with chronic, risky risk factors like patient with dyslipidemia, patient with hypertension, and so on. It's very easy to do. Who will be the industrial provider? It's not very specific things. It's not, pharmaceutical companies. It's able, Facebook, Zoom, Skype, other things. So that said, that the healthcare professionals as patients have taken the most ergonomic platform. And so for long years, we're stressing about using, Facebook and Zoom and Skype. But now everyone is using it in order to do medical consultation. And what could be the impact of the virtual visits? The potential benefits is for the patient, provide access, receive medical advice, reduce in-person exposure to the COVID-19, reduce distress. And for the clinician, it's serving patients, reducing exposure, and maintain connection between patients and providers. For the healthcare system, it's to reallocate resources and support research efforts. And so it's not only some people that are thinking of what could be the future, it's actually the reference documents from the Heart Failure Society of America. And if you're looking here, the classification of virtual services done by the US or other countries is very simple. It's based on the timing in order to have, the timing for the visits, the checking, and how long it's costing in terms of time to have the patients and to do a decision, to take a decision. Another point is the implication of the nurses. And you can see that now there are new nurses. It's nurses for telehealth visits. And so we know it in telemonitoring programs, but now they're doing only teleconsultation as other doctors. Another point is the change in healthcare professional-patient relationships. It's very, very important. For years, we say, okay, the patient could do anything because it's a disabled people, it's an old people. But what we have learned in the COVID crisis is that the patient could be very helpful. It could send us some photos, it could doing some videos, and that's very useful in order to do virtual visits. And especially in patients with chronic diseases because they're monitoring some very simple signs every day. So they learn how to do. So it's very useful for us. And due to this COVID crisis, so in the new guidelines, in the new, expert consensus, you can see usual things like resume your treatment and so on. But seeing here, so in order to follow your anticoagulation, so you can have in-home ENR self-testing, drive-through ENR testing. So it's new adaptation of our healthcare system. And it's say, okay, what we can do in order to adapt. And so not only to say to the patient, okay, you won't do anything. But now, okay, everything has changed. You will be an actor of your health. And I think it's a new change in the COVID crisis. Another point is the, perception by the patient of the efficacy or the security using this type of video virtual visits. So if you're looking at this study, which is study during COVID-19 period, so it's a patient, especially with vascular diseases and so on, you can see that here, closer you're from 5, it says the patient is highly satisfied. And you can see it's talking to the patient. I can explain my medical program, and so on. So it's very well perceived by the patient. And the patient are very satisfied. And it was really the case during the COVID-19 period, because people were happy, were less stressed, because they could have a consultation by a doctor. And so this change in the disease perception by the population is very important. Usually, disease was only for elderly, polypathologic people. And so it was for the older than me habits. And so it's the first time that we stop economic activity for saving life. And COVID-19 makes everything different. You have young patients with severe diseases. You have many people stressed about not only their work, but also about the diseases. And that's why they're very concerned about how to treat those patients. And you can see for the first time in literature, we have really the development of triage or priorization of patient to access of procedure. So between urgent, precise, semi-elective, and depending on the severity of the disease burden and the ecosystem, so the importance of the infection. And you can looking in this article, so looking to the need of the patient due to the long-term survival, the symptom status, etc., etc. So we know it. But what is interesting at the second part of the slide, you can see here, they're cutting the patient in 3 tiers. So due to the risk of mortality, and here it's depending on the COVID-19 infection. And they say, okay, if the COVID infection is low, so all the patient could be managed. But if there is a huge peak in COVID-19 infection, so maybe you only treat the 2 first tier, and the last one will be delayed because the patient has a low risk. And so it's very important thing in our daily practice. And you can see here that there is a development of fast-track procedure depending on the patient, how to limit the exposition of the patient to contamination. And it's very important because it's the only way, not only to protect the patient, but also to protect the healthcare professional teams. And if you're looking to these guidelines, so you can see that there is an integration of telemedicine and guidelines more and more. You can see here it's the number, anticipated number of cases and expected impact on hospitalization resources. Here you have the stage of the pandemic. And you can see during, depending on the stage of the pandemic, we can have televisit only, resume outpatient visit, or early transition to telehealth. So the new fact in the COVID-19 epidemic, it's the integration of all the telehealth in the usual care. And if you're looking here in electrophysiology, so what they say, if there is a high prevalence, medium prevalence, low prevalence, is remote monitoring whenever possible in all cases. So that says that during the epidemic, so telehealth was integrated in our daily practice. And the real question is how to translate it in our practice for a long time. And we're really at the crossing. And so the question is especially posed on what is the future of telemedicine and especially telemonitoring? Is it the use of telemonitoring a dream or a reality? And so I will show you some data that, about our projects that we have done in Ile-de-France, which is one region in France, with 12 million people. And so in this area, we have done a specific things with telemonitoring or all patients with COVID suspicion or COVID positive. All these patients are included by a doctor and receive every day 1 or 2 questionnaires in which the patient could answer some questions about respiratory rate, heart rate, respiratory uneasiness, chills, discomfort, fever, and so on. And we have developed a specific algorithm in order to analyze if the patient is a risky patient that could go to the emergency room or not, and he could stay at home with his general practitioner. And so we have done a specific platform, which was a centralized platform, and we have treated more than 270,000 alerts. And so let's say it's more than 10,000 alerts per day. And so it was a huge number of alerts and questionnaires, and we have formed more than 3,000 people, which are health students, in order to help us to answer to the question of the patients. And so using it, we can avoid 1/3 of the visit to the emergency room. And for the patient, it's very simple because you have a very simple things on your smartphone, and you answer the question on your smartphone. And so the goal was to allowing home care through remote monitoring with a flexible, agile, and adaptable organization. And so we have launched it in 1 week. And actually, we have developed it in many, many different applications, especially post-surgery or chronic diseases. But what is interesting is how we can integrate the telemedicine in usual care. And with audiovisual platforms, patient and caregiver participation, the staff training, patient education, and support from institutions. And actually, we are changing how healthcare, you see, pathway for chronic care due to the COVID epidemic. If I will to answer to the question, how is the impact on cardiologists? I would say cardiologists are reactive, innovative people. So telemedicine will be included in our daily life, especially for stable, far away, or disabled patients. Nurses will be included in support to telemedicine elderly patients, and the telemonitoring concepts have dramatically changed. And it may be now an impact of the analysis of the impact approach. And so the question is now, all the teams are all tied. But the question is how to take some benefit of the crisis by implementing new organization and not to repeat the old-fashioned solution. So you can have with the solar quadrants, so you can have the hour, but when it's raining, so you have nothing. You can have new, you see, hour, you can have a new clocks where you can have saturation, you can have EKG. And maybe the future is to integrate so your clock with your doctor. Thank you so much.
Well, thank you for this very energetic presentation and lots of new concepts and ideas. That was fantastic. The first thought that comes to my mind is that we cardiologists always think we need an EKG, we need the stethoscope, and usually we also need the echocardiogram. So now, which are the situations where you really need those, and how much can you do without?
Yeah, sure. But you see, I'm looking to my medical appointments every day, and I see that in 3/4 of the patients, I haven't any value, additive value, I will say, because I said to the patient with normal blood pressure, okay, you're okay. So I'm just hurting the heart of the patient that I've heard 6 months before, and it was a normal auscultation, and now it's a normal auscultation in the same way. And so what we can say is that if we're focusing our medical appointment to patients that need our expertise, so we can avoid 1/3 to 1/2 of all our appointments. And I think that really, so what we need is to detect early the signs of the patient. It could be by auto questionnaires. And after the question is how to see the patient very fast. And what we need is not only to have, you see, 1 year to have a medical appointment with a cardiologist, as we have in France, actually, but to have a very reactive cardiologist. So say, actually, what we will do in my center is to say, okay, rather to see 10 patients in one afternoon, we say 8 patients, and we have 2 places for very severe patients that we can detect using telemonitoring. And you see, in most of the case, using stethoscope, using other things, is not useful in the first level support. It's useful only in a patient without, you say, false alert, with vital problems. And so that's why we have to change how we're working in the daily life.
Yes, I mean, throw overboard what has always been done just because of tradition, right? We don't need to carry on tradition.
Yeah.
But then one concept is to see patients maybe less frequently. The other one that you're indicating is that patients can actually report their status every day. And then if you carry this further, it's going to be artificial intelligence, which listens to the patients and only puts those through to the real doctor, where some change is detected that is deemed important. Here's a question.
Totally true.
Here's a question coming in from the audience. Do you have any data that drug adherence of your patients is improved or in any way changed during the pandemic? What have you experienced? That's a question.
Yeah, you say the patient was a follow-up. What is very interesting is that, yes, we're looking to all the clinical signs of the patient every day, and we have noticed that there is, a peak in terms of risk every 10 days. So it's very, very interesting in the patients. And we have a lot of patients with some unusual signs like chest pain, and with a lot of patients with myocardial effusion and so on. But actually, so what we show is that we have actually only more than, between 3,000 and 5,000 patients that are still on monitoring, and they're very low risk profile. So it's not the same patient as it's the beginning of the epidemic.
Okay. Thank you so much, Patrick, for this